Prophylaxis against venous thromboembolism in ambulatory patients with cancer. The risk of venous thromboembolism is 4 to 7 times as high among patients with cancer as among persons without this disease. The venous thromboembolism is the second leading cause of death in patients with cancer, and overall mortality is increased among patients who have both conditions. Pathology of venous thromboembolism.
Venous thromboembolism, or VTE for short, is a leading cause of death worldwide. In the Western world, someone develops a VTE every 16 seconds. Manifestations of the disease are deep vein thrombosis and pulmonary embolism. The disease process starts, often in one of the large veins of the leg, with the formation of a blood clot. This can be due to vessel wall injuries, a pathological increase in the coagulability of the blood, or circulation deficits such as venous stasis. The resulting blood clot consists mostly of red blood cells, held loosely together by strands of fibrin. There is a considerable risk of such a fragile clot or parts of it breaking away and traveling with the bloodstream through the heart and into the lungs. Here, the clot or fragment of clot eventually blocks a pulmonary artery. The consequence, pulmonary embolism. The affected area of the lung is no longer available for the oxygenation of blood. This life-threatening outcome can be traced back to an inappropriately triggered physiological process, blood coagulation. Various medical conditions are associated with disrupted blood coagulation and therefore an increased risk of VTE. For instance, immobilization heightens the risk of hypercoagulability of the blood and venous stasis. Patients undergoing major orthopedic surgery, such as total hip or knee replacement, have an additional risk of vascular injury.
The incidence of cancer-associated thrombosis has increased, probably because of a combination of improved treatment outcomes, resulting in longer patient survival, more aggressive and prothrombotic treatment regimens against population, increased detections owing to improvement in imaging technology and frequency of imaging. Prophylaxis. Doing this against venous thromboembolism is one of the most important measures that can be taken to improve patient safety. The usefulness of prophylaxis against venous thromboembolism after orthopedic joint replacement surgery is not questioned. VTE prevention.
25,000 deaths every year, which is more than MRSA, AIDS, breast cancer, and road traffic accidents combined. You can prevent these. VTE is the term for blood clots, deep vein thrombosis, and pulmonary embolism. All patients must be risk assessed for VTE as soon as they're admitted to hospital, particularly those in high-risk groups. Make sure your patients understand the risks and give them the blood clots leaflet. All patients with an assessed risk should be offered the recommended VTE prophylaxis. All patients should be reassessed within 24 hours of admission, or after any change of circumstances. VTE prevention is your responsibility.
Prophylactic, prophylactic anticoagulation therapy. Using this in most hospitalized patients with cancer and in patients undergoing surgery for cancer has been endorsed despite limited data. Risk of venous thromboembolism. The risk of venous thromboembolism varies among patients who have cancer and it depends of a number of factors. Type of cancer, treatments, the presence of or absence of coexisting disease. PROTECT study. This is the largest study of prophylaxis against venous thromboembolism. They randomly assigned 1,150 ambulatory patients with cancer to receive prophylactic nadofarine or placebo. A study comparing rate of recurrent venous thromboembolism, bleeding, and death between patients with cancer who received anticoagulation therapy for incidentally detected pulmonary embolism and those who received anticoagulation therapy for symptomatic pulmonary embolism showed no significant difference in outcome between the two groups. When to consider prophylaxis. Prophylaxis against venous thromboembolism should be considered in patients with metastatic disease, a history of life-threatening pulmonary embolism, extensive lower extremity deep vein thrombosis, clinical significant tumor-mediated compression of large veins such as the inferior vena cava and others. And the conclusions. The venous thromboembolism results in increased morbidity, mortality, and complexity of care in all patient populations. But in patients with cancer, this complication may also lead to delays in surgery and the administration of chemotherapy, as well as an increased risk of bleeding associated with full intensity anticoagulation. Venous thromboembolism in the cancer patients summary.
Patients with 6 months to live and 6 months to live, they still have their life, and many patients are still on full responses in those 6 months. Treating thrombosis as number one is a symptom control measure. We're actually treating the reference risk of pulmonary embolus, we're treating the pain in the leg, rate thrombosis. So we're actually using it as a symptom control measure. The secondary benefits which are preventing a premature death. Palliative care, in the definition, palliative care seeks not to prolong or hasten death. But when you talk to the patients, they would want to treat it because the symptoms they have, including thrombosis and pulmonary embolism, is distressing. I think there are people who are active diets, they're taking to their bed, they're not taking oral medicines, they're out of consciousness. I think in that situation.
Thank you.